This video wraps up Chapter 25 of OEC6, and we're going to look at the management of cold-related injuries. So we'll actually begin with looking at management of a hypothermic patient. We'll talk about emergency care of an avalanche victim, but we'll deal with frost nip and frostbite as well. So watch for these key terms: that localized cold injury, frost nip or frostbite, the systemic injury of hypothermia, and the management of these patients. So let's go ahead and take a look. The general principles of treatment apply to all cases of cold injury. As with any situation, remember, part of your scene size-up is to establish scene safety and pay attention to rescuer safety. Then we move to primary assessment, and we just treat any of those life threats, ABCDs, that we have first. So if hypothermia is the primary injury or it's a secondary injury, we want to prevent further heat loss and get the patient to a place where we can warm them. So in the field in winter weather, that can be some sort of insulation beneath the patient while they're seated, or as we move them to a toboggan, use the blanket in the toboggan. This could be just minimizing some of the convective heat loss that happens when the wind is blowing by. If you need to expose an injury, make sure that you replace any clothing, and that actually includes the hat or helmet that the patient is wearing. Make sure that they're not losing a lot of heat radiantly through their head. We want to move the injured patient to shelter and out of the wind. Remember, if you're a Nordic patroller in the back country, this could be to some sort of a shelter in which heat is only available from a fire. Again, protect yourself and the patient with proper ventilation in that case. If shelter is not immediately available, one of the things to consider again is that convection. Make sure that we insulate the patient and protect them from the wind, and we watch for conduction by insulating them from the ground. Once we've really minimized the heat loss, and that allows the patient to start to warm themselves, we can look at other warming methods. So we distinguish it this way. If the patient is warming themselves, that's passive, and that happens as soon as we cover them with a blanket and their own body heat starts to be trapped and help them warm. This is accompanied by that mechanism of shivering. But we can also move to active rewarming, where we apply heat to the patient to help them warm up. This can happen externally. We can have hot packs or hot water bottles that we use. This is inadequate for moderately or severely hypothermic patients who are not shivering. And so in this case, we may even elevate that if we have an electric blanket or something available in the clinic or first aid room. Internally, we can also start to warm the patient by offering warm beverages. Make sure that you don't have the potential for an airway problem. Make sure that they're fully responsive and that they don't have this diminished motor skills. They're able to hold that in their hand and swallow without choking. These high energy drinks could just be as simple as a cup of cocoa, and that's going to provide not only some of that internal warming, but it's going to eventually give them fuel that will allow them to warm themselves as well. In a moderately or severe hypothermic patient, aggressive warming, such as whole body warm water immersion, shouldn't be attempted because the severe drop in blood pressure that occurs could lead to VFib. We don't want to rub the extremities because it really doesn't do much in terms of frictional heat, and we can damage the skin as well. What we want to do in these cases, moderate to severe, is really transport them to definitive care as soon as possible. Now, if a patient is severely hypothermic and we assess that they're bradycardic or perhaps even absent of a pulse, understand that that could actually be just resulting from a very, very slow, very bradycardic and faint heart rate as well. So we still want to begin treatment immediately. Remember, they are not dead until they are warm and dead. What does that treatment look like? Well, as always, open the airway, check for breathing and pulse, and check that pulse maybe not for 15 or 30 seconds and multiply by 4 or 2, but check it for up to a minute. Their bradycardia can be so severe that a pulse is very hard to detect. If cardiac activity is not detected, we can initiate CPR. We've got this life threat. Rescue breathing is also going to be indicated in this case because improved ventilation may help with that cardiac activity. Specific procedures for providing CPR can be confirmed with your local medical advisors. If we want to begin chest compressions, just make sure that we understand that for a hypothermic patient who has signs of life present, we're not going to initiate that because we want to focus instead on heat loss prevention and this either active or passive warming and dealing with perhaps traumatic injuries that may have occurred. Multiple case reports indicate survival from accidental hypothermia can occur, even with prolonged CPR and downtimes. These patients are going to benefit from resuscitation, and we want to just realize that their presentation as pulseless or severely bradycardic, is accompanied by this cold injury. So we want to make sure that we don't consider them to be dead or have them declared by higher authority until warming has been provided. This chart is an excellent summary of what we should consider moving from mild to moderate to severe hypothermias in these cases and the treatments that we can follow. More specifically with CPR, use of an AED may be beneficial, but the protocols can vary. And in fact, the American Heart Association hasn't exactly established the temperature at which this patient that we are warming up from being severely hypothermic should be initiated. Up to 3 shocks are recommended in a patient with severe hypothermia while rewarming is ongoing, and we'll continue chest compressions just following our BLS protocols. We'll attach an AED to the patient as soon as it is available. If the AED says shock advised, we can defibrillate. And according to the Heart Association in 2018, it may be reasonable to perform further defib attempts according to the standard BLS algorithm alongside our rewarming strategies. Now, a patient with mild hypothermia who's been adequately warmed and returned to normal mental status may not need to be emergently evacuated. Just be sure not to allow recurrence of a cold injury. Any patient who does not respond to warming with moderate to severe hypothermia or who has severe frostbite alongside the systemic injury of hypothermia must be evacuated as soon as possible. And this needs to be done gently. The localized frostbite injury could be further damaged if we're not gentle. Systemically, we want to avoid that VFib that can occur. During transport, continue to monitor their vital signs and continue with your rewarming protocols. Now, focusing on those localized pieces, frostnip, that superficial form of frostbite, is usually treated by seeking shelter and warming the affected area. This could be with chemical heat packs. We want to place those not directly on the skin, cover them with a cloth so that it's not too hot. And then remember, don't rub the affected body part. We just want to make sure that we're warming it. For frostbite, rapid warming is indicated. And the way that we're going to do that is by immersion in warm water. And we'll talk about that in a couple slides. Just be aware that warming can cause pain, sometimes severe pain. We need to explain that to the patient. Among the many factors to consider when rewarming is when and where we're able to do that and how those should be performed. So the tissues should be warmed as soon as possible upon assessment of this frostbite, and in some cases before transport to a medical facility. This will avoid further injury to those tissues. But we also have to apply judgment, and especially if you're a Nordic patroller, perhaps in the back country, we don't want to allow warmed tissues to refreeze due to further exposure. So if shelter and equipment are not available, consider not rewarming the tissue in that case. Here we see that more specifically stated. If you're in the backcountry and shelter and equipment are available, if rapid warming is possible without refreezing, go for it. Thaw the body part. If the decision is made not to warm that tissue in the field, really protect the area from additional injury. And if you're on your own and have to self-evacuate, you may make the choice to leave that foot frozen to avoid the pain that occurs upon thawing and rewarming. So we'll do this warming in a sheltered area, keeping in mind we can avoid conduction and convection heat losses. Assemble the equipment. Hopefully we're inside our medical facility, perhaps clinic or first aid room. For Nordic patrollers in the backcountry, that may be a cabin or a hut. And so our particular protocols will be to take off any constrictive clothing or watches. Make sure that we've got a warm water vessel large enough to accommodate the entire limb. And then make that warm water bath about 102 to 104 degrees Fahrenheit. This should just be comfortable to our hand that's placed in the water. A lot like maybe setting up a bath for a baby. Suspend the frostbitten part in the center of the warm water bath, and we can begin to warm it up, keeping it in the bath for about 20 to 30 minutes. We'll keep adding warm or hot water as needed to maintain that temperature of 102 or 104. We'll stir the water to make sure that it's nice uniform temperature throughout, and then allow the affected part to air dry when we're done. Don't rub the tissues. If we have that superficial tissue damage, it may slough. Once the area is warmed, it's possible that particular lotions may be effective or assist with the comfort of the patient. Dry dressings may be applied. They may want some sort of analgesic, ibuprofen or aspirin. These are also a little anti-inflammatory. But if the pain is very severe, remember, transfer to ALS so they can use narcotics for pain management can be indicated. Now, we'll wrap up with discussion of what to do for an avalanche victim. In the case of an avalanche victim, understand that asphyxiation is the major cause of death during burial. We have the secondary issue of hypothermia, and we also have the potential for serious trauma when that patient is wrapped in that slide and brought down that particular slope. Trauma is going to have its own possibilities in terms of impairing thermoregulation, can accelerate this secondary issue of hypothermia. The major life threat is going to be that asphyxiation. So if the person can breathe underneath the debris field, toxic levels of CO2 are going to build up around the face. If we get to that patient within 15 minutes, their chance of survival goes up to greater than 90%. The potential for survival decreases a lot when we approach about 35 minutes after they've been caught in that debris. Survival beyond 35 minutes really just depends on whether or not they had an air pocket and can expand their chest for breathing. So if we extricate a victim of an avalanche, the real priorities are going to be open the airway and ensure adequate ventilation and watch for trauma with major bleeds. We can provide supplemental oxygen and maintain spinal motion restriction for our transport. And if they have severe hypothermia, we'll just follow our hypothermia treatments and check pulse and respirations for up to 1 minute, understanding that that pulse may be difficult to detect because they're so severely bradycardic. So the severity of hypothermia may be assessed by really just thinking about the level of responsiveness. If the avalanche victim is responsive and they've been buried for less than an hour, they're probably still in this mild hypothermia region, and so warming's going to occur through shivering. Development of hypothermia during an avalanche burial does not occur as quickly as during cold water immersion. Cold water immersion, we have much higher heat capacity of the water. It's going to sap the heat from our body much more quickly. Generally takes more than 35 minutes of burial in an avalanche to cause moderate to severe hypothermia. Now remember that traumatic injuries can accelerate development of hypothermia. We're also still likely out in the cold and with the wind, convective heat loss, so handle the patient gently and understand that these symptoms can set in a little bit later. Proper packaging is critical. If they have a depressed level of responsiveness and are not shivering because they've progressed to moderate or severe hypothermia, we're going to have to transport them for definitive warming in addition to the other possibilities that have occurred, such as trauma. Unresponsive avalanche burial victims who are breathing are likely moderately to severely hypothermic. After extrication beyond 35 minutes from burial, if the patient is pulseless, they probably have died from asphyxiation. It's unlikely that resuscitation will be successful, but we begin CPR anyways on this pulseless victim. If we're unsuccessful after 30 minutes, the patient was probably dead before we were able to extricate them. However, we continue CPR until higher level personnel assume care. If the burial time is greater than 35 minutes and the body temperature is less than 90 degrees Fahrenheit, the victim may be severely hypothermic. We see this low body temperature, and so we'll continue those resuscitation efforts during transport to a medical facility.